Let's start that. So, hi everyone. Welcome to everybody to our webinar. Today we'll talk about thyroid molecular testing, how you can interpret that, the results, in order to support your clinical decisions. And yes, a very common question we are answering from the beginning. It's available in your country, no matter which country are you based in. So two quick messages here. The session's been recorded. So if you are here and you need to ask anything, this will be recorded, and then it will be available in our YouTube. And also all the questions that you have, they can be sent through our chat. On your right, we have a chat. Please send all the questions that you have, and I will be very happy to answer all of them. So very nice to meet you. My name is Marcos Santos. I'm a scientist. I'm a PhD in human genetics and molecular biology by Unicampi and University Clinic of Cologne in Germany. I'm also a senior researcher from AC Camargo Cancer Center, the largest cancer center in Latin America. And I'm the principal researcher that was involved in the development of the molecular test that we'll discuss today, which is called mir-THYpe Full. So due to that, I'm declaring my conflict of interest because I'm the chief of science who developed the test. The name is mir-THYpe Full, but I'm also the founder and the CEO of the lab who offers the test with Onkos Molecular Diagnostics. So this is the name of the lab and this is the name of the test. But all the data that I will bring to you here is based on evidence, high level of evidence. So just to let you know in a very quick way, who is Onkos? So we are a global molecular diagnostic laboratory. We have two offices. We have an office in Barcelona and an office here in São Paulo in Brazil, but we have more than 30 countries worldwide that the patients are being tested. We have tested more than 7,500 thyroid patients up to date. And we are very proud that we are a CAP accredited lab. This is to the ones that are not familiar with, this is the main lab quality accreditation seal in the world. It's a very selected list of labs who have that. So this is just to show how we are committed with quality to the test that we offer here. But okay, let's talk about thyroid nodules. And I always like to start saying about the limitations that we have for the FNA, the fine needle aspiration. As you may know, the majority of the FNAs are benigns. We will use during this presentation the Bethesda system, so the Bethesda 2, but it corresponds to our colleagues from Italy for tier 2 and for our colleagues from UK and other countries that use the THY system, which is the THY 2. And those patients usually undergo the follow-up. For those minimum amount of patients who have suspicion for malignancy that are Bethesda 5 or 6, usually those patients undergo the surgery. But we have the problem here with the indeterminates, which are between 20 to 30% of the cases, Bethesda 3 and 4, which is also known as tier 3 or B or THY 3A or 3F. But the problem here is this nodule benign or cancer? So usually what we do is the diagnostic surgery, but the problem is only 20% of those cases are really cancer. The majority of those cases are benign. So we have a lot of surgeries that we could avoid them. We have a diagnostic problem. And on the other hand, we also need to understand the better plan to that surgery when we have a cancer. Should we do a total thyroidectomy, a lobectomy? Should we look to the lymph nodes? So we also have a prognostic challenge here to overcome. So what does the medical guidelines suggest for us as official recommendation? So molecular tests are very widely available. Here I bring the main ones, but it's worldwide recommended. European Thyroid Association, American Thyroid Association, NCCN guidelines, all of them recommending on indeterminates to perform molecular testing. And it's also very interesting because the European thyroid guidelines, they say you should do molecular testing if available, because currently there is no molecular test available in Europe that is well validated. So, well, now we are in Europe available for our colleagues from Europe and for all the world. But have you ever think why do the guidelines recommend the molecular testing? Because we will discuss today, it's all about the risk of malignancy. You will hear me say in this world today a lot of times, risk of malignancy. Why? Because all the clinical decisions that are supported today in the thyroid patient journal is based on risk of malignancy. When we look to the ultrasound, there are many different systems, but all of them say about the risk of malignancy and what you should do based on that risk of malignancy. When we go to the cytology, it's just the same, no matter which system do you use, always will talk about risk of malignancy. So risk of malignancy is the main thing that guide our decisions, right? So when we look to the Bethesda system, the cytology system, when we say Bethesda 2 or type 2 and etc., we call it benign, but we know that it's not 100% benign. We have a residual risk of malignancy, according to the literature, between 2 to 7%. So this balance is tilting to follow the patient. It's very low risk of malignancy. This patient do not deserve a surgery in the majority of the cases. So what we usually do with this very low risk of malignancy, we follow that patient. On the other hand, when we have a Bethesda 5 or 6, we call it, for example, in the Bethesda 6 as cancer, as malignant, but it's not 100% risk that it's malignancy. We have 2 to 3% on Bethesda 6 that will be false positives, but it's very high risk of malignancy. So this balance, it tilts to the surgery. So this patient will be benefit from the surgery, even if it's not a true malignant. So it's very well supported to perform the surgery. The problem is this gray area, that is the 3 and 4, where the risk of malignancy is not, it's not too low and it's not too high. So that's why we call indeterminate. So what should we do here? Should we follow or should we do the surgery? So what we need to find is a method that could take this balance to something with a risk of malignancy close to a Bethesda 2, or to take out this gray area and to tilt that balance to something with a risk of malignancy close to Bethesda 5 and 6. So we can support our decisions. What we cannot support is this gray area, right? But how we can take this patient out of this gray area? So we should use all the information that we have. Clinical data, cytology, ultrasound, and when needed, molecular testing. So if you have clinical data, cytology, ultrasound, and the risk of malignancy is still indeterminate for your clinical decision, here is when you should think about molecular testing. Because now you have virtually all the data that is available, and now you can support a more informed clinical decision. So the best definition that I heard is that the molecular testing is a room redefiner, because we want to redefine the risk of malignancy of a nodule. But how does the mir-THYpe food, the test that we will discuss today, how it refines the risk of malignancy? So it's important to understand that this test has two components, right? The first is the diagnostic component, and the second is the prognostic component. So on the diagnostic side of this test, we'll try to answer this question. Is this nodule more likely to be benign, which means a very low risk of malignancy, or malignant, which has a very high risk of malignancy? So we can decide between follow and surgery. On the other hand, the prognostic markers will try to answer this question. Is this nodule potentially aggressive? Because this information will be helpful to help on the surgical extension plan. So let's start talking first around this diagnostic part of the molecular test. So just for you to understand, this test is based on microRNAs. MicroRNAs are very small molecules that are involved on the regulatory pathway in our cells. So we are not talking about mutations here. We are talking about expression, the quantity of those microRNAs that we have in the cells. Maybe you saw that the Nobel Prize last year for medicine was for the researchers who described the microRNAs. So how does that work? So we have two parts in the test. We have the part that is being performed in the lab, and then we have a part that is bioinformatics, mainly artificial intelligence. So when we have an indeterminate nodule, we quantify a panel of microRNAs. And these microRNAs will generate an expression profile, a very specific profile. It's a type of genetic signature, right? And then when we have this quantification from the indeterminate nodules, we will use this algorithm to compare with two large databases that we have. We have a large database of nodules that are known to be benign, and we have a large database of nodules that we know that they were cancer. So what we basically do, we will compare if this indeterminate nodules is more likely, it's more similar to the benigns, or it's more similar to the malignants. This is how we will split that nodule into benign or malignant. But using this method, how accurate is this microRNA-based algorithm? Which means what's the diagnostic performance of this test? So to answer that question, we have two retrospective studies. And both we compared in a blinded study, the molecular test, the mir-THYpe full, versus the surgery. So all the patients have undergone surgery, and we know if they have benign or malignant nodules. The first study was published in 2018 in the Thyroid Journal from the American Thyroid Association. It was a study with 173 samples from two sites. And the new version of the test that was presented last year in the European Thyroid Association Congress and also on the American Thyroid Association Congress, it's a more robust study that will be published very soon, where we analyzed 510 samples from 14 sites from 3 countries. But the thing is, we arrive in very similar results on both validation studies. 96 to 97% of negative predictive value and 76% of positive predictive value. So to the ones that are not very familiar with predictive values, what does those numbers mean? So a negative predictive value is the chance, the probability that a negative result will truly be a benign nodule. On the other hand, the positive predictive value is what's the chance when we have a positive result that this nodule is truly cancer, right? So why those numbers are important? Because what does it mean in the practice? So let's go back. It's all about the risk of malignancy. Because when we have a nodule in this area, here is the best place where we can put a molecular test. Why? If the result is negative, it means, as I show you, 96 to 97% negative predictive value, which means a residual risk of malignancy between 3 and 4%. which is statistically very similar to a Bethesda 2. So now we are transforming this nodule in a risk of malignancy as Bethesda 2. So your decision is the same that we will take if it was a Bethesda 2. And for the positive nodules, the logic is just the same. 76% means 76% risk of malignancy, which is very close to a Bethesda 5 or 6. So it should support your decision. That's usually a surgery, right? So again, molecular testing is a risk of malignancy redefined. But what about the other markers that I told you, the prognostic markers? So we will see that they have the potential to put this risk of malignancy to up to 99%. So let's talk about the second component of the test. So here we do not have a very large panel as the other tests do, because we just have the markers that matter, the ones that we have evidence that they really change the decisions. So we have the expression of those two microRNAs, and we also analyze mutations on BRAF and TERT genes. So when they are positive, the risk of malignancy just increase a lot to something always higher than 90%. So it's virtually, you know that you are facing a cancer. But they also predict generally a worse prognosis. When we have the microRNA 376, 375, we know that this patient has a medullary carcinoma. It's a typical marker of medullary carcinoma. So all the surgery and all the treatment of this patient will be based on the information that the patient is a medullary patient. For the 146B, we have this a very good predictor of lymph node metastasis in central neck on the level 6. So when you have that, you should at least investigate the lymph nodes because they could be positive. And when we have the mutations, especially when we have both mutations together, BRAF and TERT, this is the worst molecular situation that is known currently in the literature, because when both are positive, we have higher risk of recurrency, extraterritorial invasion, distance metastasis, vascular invasion, multifocality, and also an increased risk of death. So this would help on understanding how to treat and how to plan the surgery of those patients. Let's remember that ATA recommends BRAF and TERT since 2015 to better stratify those patients. If you know the status of those two genes, you could better stratify them between high, intermediate, or low risk. ETA and NCCN guidelines, they also started to discuss the clinical utility of those markers, and it's gained a lot of force, the use of those prognostic markers. So, okay, we tested all the markers from your patient with indeterminate nodule, and how does it reported to you, and how it helps you. So our report is very simple, concise, and self-explanatory. It's you don't need to feel fear about the genetic test because it's very, very simple. We can provide it in 3 different languages currently, in English, in Spanish, or in Portuguese. We have only 2 pages, the front page that I will discuss better, and the other page that has some text supporting the results, what does that mean, and all the reference that we use it. So in the first page, we have patient details, and then we have regarding the sample that we received, where is the location of the nodule, the classification, and other technical details. But the main part is here, the final results. So all the reports, they will have a binary diagnostic conclusion. So we always will classify negative, or positive. There is no intermediate, right? We will tell you the final risk of malignancy of that nodule. We will always also describe the status of each of the markers that were analyzed. And here we made something more visual, where we are comparing the new risk of malignancy with the Bethesda system, right? So we have the pre-test risk of malignancy and the post-test risk of malignancy to make it more simple to understand where this patient is. And that's it. So let's see some examples here. So an example of a negative nodule. So when we have a negative, we know that we are facing a very probably benign nodule. Why? Because the microRNAs are very similar to the ones in our database that we know that they were benign. And all the prognostic markers are negative, right? We have also the risk of malignancy. So as I told you, our NPV is 96 to 97%. So that's why the risk of malignancy is the residual risk of malignancy. And again, as I told you here in this example, we have a patient with a Bethesda 3, which has 12 to 30% of pre-test risk. And now with the new classification, the new risk of malignancy is something around the Bethesda 2. So that's not a coincidence that it's here on the same place as Bethesda 2. So what we did here, we just made the balance to tilt, to follow the patient, right? So let's consider some facts about the negative results. About 3 to 4% of the cases are false negatives. They will be cancers, right? But again, just like in Bethesda 2, it happens in the same frequency in Bethesda 2. But the advantage of the molecular testing is that even if this is a false negative nodule, we know that this nodule has a very low potential of aggressiveness. It's probably a very indolent cancer because it has all the negative, all the prognostic markers negative. So the chance to be a very aggressive cancer is very low. So it will not have a potential to bring so many problems. And again, just like Bethesda 2, the most common procedure is follow-up, but we also know there are some Bethesda 2 cases that could be surgical, and here is just the same here. One example of a positive case, so it's positive here, we know that it's probably a cancer, right? Because it was similar to the malignant ones. But in this example here, we have a cancer that the negative, the prognostic markers are negative, right? So this is the PPV that I showed you, the risk of malignancy. And now we reclassify that patient from a Bethesda 3 to something here close to a Bethesda 5. So this patient would benefit from a surgery. But what are some facts about this result? It's most likely cancer. We have 76% chance, but potentially an indolent nodule. The negative, the prognostic markers are negative, right? If all the other characteristics allow that nodule, this is a good case to consider lobectomy or even an active surveillance, right? Because, okay, probably a cancer and no potential aggressive markers for that case. And we need to know around 24% of the cases with this result, they will be false positives, just like in Bethesda 5. We have the same proportion in the Bethesda 5, right? And another example of a positive is when we have a positive case with some positive prognostic markers, right? So in this situation, the risk of malignancy just increased a lot because we have a BRAF positive here. So now we reclassify that nodule to something around a Bethesda 6. So how we can interpret that? It's a cancer. and it has a higher risk to be more aggressive, to have a worse prognosis, because we have BRAF and this microRNA positive, right? So this patient minimally will deserve a detailed lymph node investigation, and the more likely surgery to be offered would be a thyroidectomy, but also need some cervical evaluation need to be considered. It's very unlikely to be a false positive. When we have a BRAF and this microRNA, it's very unlikely, just like in Bethesda 6, which is also very unlikely to have that. So let's remember, this is not all about molecular testing. We need to merge clinical, cytology, images, and the molecular test to have our clinical decisions. And in practice, does it really reduce the number of surgeries? So we answered that question with this study that was published in the Lancet Discovery Science, the journal. It was a clinical utility study, a prospective, real-world, and multi-center study. We followed 435 patients, all Bethesda 3 and 4, that were tested with the mir-THYpe in real world from 128 sites, and we followed them up to 2 years. So in a very summarized result, what happened? We reduced 52% of all the surgeries. And when we look to those surgeries that would be potentially unnecessary, we reduced 75% of them. And 92% of the clinical decisions were made based on the molecular testing results. So yes, molecular testing has the power to reduce surgery, and it's a very cost-effective plan to not only improve patient outcomes, but also save money for the payers. So how to order that? Yes, in your country, anywhere in the world, how can you order that? But before we describe how to order, let's try to understand why you can order our test from anywhere in the world. Because as we call, this is a triple A test. There are 3 reasons that we say that it allows you to order the test in any place of the world. It's accurate. As I show you, you have a very strong scientific data supporting the use of the test. It's affordable. The cost of the test is between 3 to 5 times lower than the tests that you know from the US. And it's accessible. But what should I mean with accessible? Because we don't need a new FNA biopsy. The patient don't need to do a new FNA. We use exactly the same existing FNA cytology slides, the smears. The one that the pathologist classified, okay, this sample is a Bethesda 3 or 4, that's the material that we need. And it's a very good advantage because we will analyze exactly the same cells that the pathologist classified as indeterminate, right? If these slides have up to 5 years since it was collected, they are validated to be used. So we have no extra costs with a new FNA. For the patient, it means also no extra pain and no extra visits to the clinic to perform new FNAs. And all the logistics are room temperature. So thank you to microRNA's stability. The microRNAs that we analyze, they are very, very stable. So all the logistics from any place in the world, they can be done in room temperature. So getting back to that question, how can you order it in your country? Is that simple. Just email us international at mir-THYpe.com, or you can go to our website and send us a message. We will organize first the logistics. So we will pick up the sample directly in your office, in your clinic, in your hospital, wherever the sample is. We will send a FedEx, a UPS, a DHL person, and they will pick up the sample. all the documents that you need to send that sample will be provided by us. We'll send to you the email. Okay, you just need to print. It's a one page. You print that page and you tell us, okay, the sample will be available tomorrow at 10. Then somebody goes to your office and pick up it. Any place in the world, right? And the second thing is the payment schedule. So if your patient will be paying the test, we will arrange directly with your patient that. If you want to put it in your hospital, we can do contracts with the hospital or with the clinic or with the healthcare system. It's a very simple way to solve that. That's simple. Just email us and we handle with everything. Another thing that I would like to bring to you is that we have a specialized channel for physicians. So if you have any technical or scientific question, if you want to discuss any case or to interpret the results, or if you need any materials, please reach out to us. This is the number of our WhatsApp. So you can just ping us here or in our website, and let's try to help you on that. And finally, I would want to invite you, everyone, to visit our booth during the ITC, the International Thyroid Congress, which will be held in Rio this year from 18 to 22 June. We have a good booth there. This event is a joint event from American Thyroid Association, Latin American Thyroid Association, European Thyroid Association, and Asia and Oceania Thyroid Association. It happens only each 5 years, so it's a big opportunity to be in the main thyroid event in the world. So thank you very much for your time and for your availability. Here is our Instagram and all my contacts and our website. If you want to receive any materials or any type of information, just scan that QR code. And now, please, let's discuss all your questions. And my colleague, Carol, will help us with those questions. Thank you very much. Carol, não estou te ouvindo. Carol? She's trying to connect. Let's see the question. So while Carol is trying to connect, I will try to read here the questions. Good afternoon. If we have data of the correlation of the pathology with the molecular data, which has the 76 risk. Yes, this is those studies, Dr. Diana. Thank you very much for your question. This data came from those two studies that we showed you. And due to time here, I didn't show that paper from Lancet. We also analyzed the patients that has undergone surgery, what happened with them in the pathology, right? And we didn't see too much difference on the cytology, sorry, on the pathology results. We know that it will be published soon, an independent study from Imperial College in the UK, and also from other groups that are using our test. Although we don't know the results yet, but we heard that the results are very similar to what we have seen in our studies here. So yes, we have this data, and I can share the papers with you. I'll be very happy to do that. Tainara, Carol, are you back?
I think I am.
Yes, I can hear you now.
Oh, okay, thank you. Sorry, guys, technical problems. You were going to read Tainara question. Tainara asked how she can request it from another country. You explained, but can you go back a little bit?
Yes, Tainara, thank you for that question. As I said here, it's very simple. And something that I forgot to say on this slide is that we also have partners in many different countries. So, especially here in Latin America, in Africa, and some countries in Europe, we have local partners. So you can find them in our website. If you have a partner in your country, so just reach to them. They will handle everything for you and for your patients. But if there is no partner available there, you just connect directly with us and we will help you on sending the samples. Okay, it's very simple.
Great. Raquel asked if the patient needs to do a new FNA to do the test.
No, Raquel. We don't need the patient to do that. Just if the slides has more than 5 years, so then the patient would need a new FNA. And of course, enough cells. We need as low as 60 cells to do the test. So if it's a Bethesda 1, we are not able to do the test currently. But if we have more than those amount of cells, we can perform the test with no problem. Any type of staining, any type of fixation are also validated to perform the test.
Oh, Marcos, can I ask you something about this this part? When the sample is not good for the test, what happens?
Okay, very good question, Carol, because when the sample arrives in our lab, before it undergoes the molecular test, we have a pathologist, a very experienced pathologist, who will check the sample first to check if there is really enough cells and good quality for that. So this is the first gate, let's say like that. If the sample is not enough, we will stop here and we will ask a new sample. At this stage, we didn't have any cost. So if the patient don't want to do a new FNA, we can give the money back. Once it's validated from the pathologist, this enter in the lab and the test will be run. We have between 1 to 2% of the samples that fail due to many different reasons, usually low quality or something in the collection that we cannot detect. And then we will have two options. We can report as an inconclusive result, or we can ask the patient to do a new FNA and send the samples to you with no cost. We will repeat that, no cost for the patient if the first sample was not enough. Something that is very important is always send all the slides, right? Usually we will use just one or two, but if we need to confirm any result, if we need to repeat something, please send all the slides. The ones that we will not use will be stored here. And if the patient needs that, we can send them back, no problem. But it's better to send all the samples available.
Great, thank you. We just received a new question from Raquel, and she asked how much for the test.
Okay, I was waiting that question. It always comes. So okay, it ranges from country by country, right? The logistic, because we have the test cost and the logistic cost, right? The test cost, it ranges from 900 to 1,200, depending on the country, right? And the partner and many different things. And the logistics usually cost between 100 and 150 US dollars. So if the country is closer or has a better access, it will be cheaper. But it's important to understand that the logistics are per sending, right? Not per sample. So if a hospital or a clinic is sending 10 samples at once, the cost will be the same for the logistics and then the cost for each test. which is much more lower than the other available tests.
Marcos, someone is typing, so I will wait for the question. But Andrea Iglesias, no, pardon, Sudeshna asked if the record is going to be shared.
So hi Steshna, nice to see you here. Yes, we are recording this session, and once we finish that, our team will work on edit it, and when it's available on our YouTube, you will be able to watch it there.
I've just shared the link for the page that you can see our partners internationally, Marcos, so can help who are here in the webinar. And the question is here. Katerina just asked, hi, do the test proportion of thyrocytes in a sample before analysis? Do eliminate false negatives? Example, lymphocyte DNA. Thank you.
Hi, Katerina. Thank you for this very good question. Yes, when our pathology take the slides, he will demark only the thyroid cells, the group of thyroid cells, right? So we do not scratch the whole slide, all the cells. We will just scratch the places where the pathologist demark to extract the DNA and the RNA. So we take this this detail just to avoid what you are worried about.
Marcos, another question from Luis. What are the requirements of cytology slides to perform molecular tests?
Hi, Luis. Thank you for the question. So there are just a few requirements. The slide needs to have up to 5 years. If it has more than 5 years, we cannot. It's not validated to be used. It could be any staining method and any fixation method, right? We would prefer, of course, to use the small glasses inside instead of spray. Some labs use spray. It's the same for us, but I mean the glasses are easier to do. And of course, we would avoid using heparin tubes when collecting. It's not used anymore. It's just very few places in the world that are using that because heparin will bring some troubles to the PCR reaction. So in general, any type of slides, any staining and fixation, and up to 5 years.
Well, we don't have more questions. People are thanking you very much for the webinar. I would like to end it.
So thank you, Carol, to help us here with the questions, and thank you everyone to be here till the end. I'm always available if anyone wants to discuss anything. So just reach out to us and we'll be happy to help you to save thyroids in your country. Thank you very much. Talk soon.